what our intent will be is approximately 30 to 35 minutes or so, walk you through what is currently known about the COVID-19 viral outbreak. And then following that, open it up for questions and address some of your questions via the chat lines. Okay. So there is some concern about a question about the volume. Can you hear me any better now? Okay. All right. So with that, we'll go ahead and get started. Thank you for your patience as we are making sure that the audio and the visual functions are good. Thank you. All right. So here's the plan for the evening. The objectives of today is I will start off by describing the origin and the spread of COVID-19 in China and then across continents. There is a certain logic to this, so you are able to understand some of the basic fundamental principles of the origin and the spread. We will then go on to compare and contrast COVID-19 with some of the more common viral illnesses. And there is, again, a certain amount of logic to it that helps us predict a little bit. And if all of you know it, you're in a better position to be able to make sense of what you hear in the media and elsewhere. Third, we will then condense for you the current state of knowledge regarding the disease. What is it? What kind of virus is it? What does it resemble the most? How is it spread? And that will set the foundation of presenting to you the scientific principles as it relates to prevention. And finally, we will describe for you common preventive techniques to prevent transmission. So here are the details, and with that, we get right in. So most of you know that the first discovery of this came from China, a place called Wuhan, China. And this journal article, which was published February 20th in one of the most lead journals of the country called the New England Journal, summarized all of the scientific information that came from those first few cases in China and following that. So here's what happened. In late December 2019, local health facilities reported a cluster of patients with pneumonia. These cases were linked to a seafood and wet animal wholesale market in Wuhan, China. And the reason I put that little picture on the side as an insect for you is that this gives you a flavor of what this market looks like. It's an open market. A whole variety of animals, in addition to fish, are traded in this market. And two important things to that. One is, when I say open, it means it's all kinds of meat, including fish, are sold out in the open, kind of roadside, not refrigerated, not in any other way treated, but open. Secondly, that a wide variety of animals are traded. And these animals are typically slaughtered live right there. And the types of animals can be fairly mundane to pretty exotic, including things like bats, deer, and even bear. The reason I mention that is for a very specific reason, which is that what that means is it gives us a clue into what we can learn from where the virus may have originally come from. Then on December 31st, fairly quickly, and there are a lot of lessons to be learned here from the Chinese CDC dispatched a rapid response team to conduct an epidemiologic investigation. And here were the initial 3 cases. Each one of this has some learning for us. Patient 1 was a 49-year-old woman. Patient 2 was a 61-year-old man. And patient 3 was a 32-year-old man, from which more details are unavailable. So the very first patient, the 49-year-old, came in with main symptoms of fever, cough, and some chest discomfort. And 4 days after she got sick, her cough and chest discomfort worsened. Of note, she was a retailer in the seafood wholesale market. A diagnosis of pneumonia was made based on a CAT scan. And very interestingly, she recovered and she was discharged on January 16th. The second patient was a 61-year-old man. He had fever and cough. He then began to go into respiratory distress that kind of worsened over the next couple of days. He had been a frequent visitor to the wholesale market, And he, very unlike the first patient, rapidly got worse and died on January 9th. Testing revealed essentially from lung fluid samples demonstrated viral particles. And this is a fascinating study where the article that I showed you earlier on comes from the CDC China and published in the New England Journal. Very rapidly, they had identified the virus. And interestingly, testing showed that there was an 85%, call it contiguity, meaning similarity when you looked at the DNA with a bat SARS-like CoV virus, indicating that this may be something similar to something coming from bats, if you will, an association with bats. And the isolated virus at that time was named the 2019 nCoV. So the conclusion was the likely causative agent of viral pneumonia in Wuhan is a novel coronavirus. And you don't have to remember the details of the names and so on, but this is where the name actually comes from. So what are the coronaviruses? This is important because the more you know the scientific background, the more you are able to make sense of how treatment is being planned and how prevention is being planned. So these are RNA viruses distributed among humans, other mammals, and birds, and cause a whole variety of diseases that include respiratory, stomach and GI type things, liver type stuff, and neurological diseases. Very interestingly, and this again we will come back to again, which is that prior to the novel strain, the one that I was just talking about, there were 6 known coronaviruses that were known to cause human disease, and here they are. You don't have to remember the names of the first 4. Suffice it to say that the first 4 listed here, they cause a common cold-like illness in immunocompetent individuals, meaning normal people like you and I, with no underlying heart disease, lung disease, and so on and so forth. These things easily get better on their own. There is really nothing to worry about. It's just like another virus. It's like a common cold. And then the next 2 are a big deal. You and I both know about these because they created havoc in 2002 in the case of SARS-CoV, and in 2012, MERS-CoV, called the Middle Eastern Respiratory Syndrome coronavirus. Both of these had an extremely high fatality rate. As you know, they spread like wildfire, very similar to what the current virus is. And finally, the novel coronavirus, as it began to be called, which came out obviously in December. So the reason I show this slide and spend a fair amount of time on this slide is that there are a lot of learnings, and much of the predictions going around right now have been comparisons with the SARS and MERS-CoV. So in the New England Journal of Medicine, the editorial at that time pretty loudly proclaimed, for the 3rd time in as many decades, a zoonotic coronavirus, zoonotic means something that comes from animals, has crossed species. In this case, the thought was that it maybe has crossed from bats to humans to infect human populations. And at that time, we felt that perhaps it was just a spread from an animal to a human, but then very quickly it became apparent that it was spreading rapidly, and the rest, as they say, is history. And we won't belabor this slide. It began to spread across the world. I just want to take 30 seconds to draw your attention to something that I will keep coming back over and over as you begin looking at the spread across the world, that a site, the most credible site to go into and look at this in terms of where the situation of the epidemic is as of right now, is the CDC website, cdc.gov. And there is a very nice interactive map on that site where you can hover over the map and go to any country, and it'll tell you the details of that country at that point in time. So it's a very worthwhile one to take a good look at and get comfortable with as you as consumers begin to follow the epidemic. The other thing about the CDC website is, I've pointed this out in the left lower corner. You can sign up for email updates from there, where you can get daily emails that kind of give you a quick rundown of where the coronavirus is. So you don't have to depend on less credible sources, but hear it from the horse's mouth, which is the CDC. So as you might imagine, after the spread, this again is very well known right now, so I won't belabor this. There are 5 countries to which there are travel notices. China, Italy, South Korea, and I apologize, this is a typo there. These are level 3 travel notices or advisories, which means that avoiding all non-essential travel. And in the case of Japan, it's a level 2, which is older adults and those with underlying diseases consider postponing. Quite honestly, level 2 or 3 doesn't matter at this point. People have severely restricted travel, and these countries have obviously, unless there is an absolute need to be there, pretty much most tourists at least are not heading in that direction. This is COVID-19 at a glance today, as of this morning. Won't belabor this because you can get this from a zillion sources, including every night in the news and so on and so forth. Importantly, that person-to-person spread in the United States has become fairly well established now. And if you see in the bottom of the slide, there are 18 instances of direct person-to-person spread. Now, the reason I show this is twofold. One is that person-to-person spread has become well established, but secondly, to also show you, despite the seeming panic and alarm, the total number of cases of person-to-person spread as we speak are basically only 18, right? Most of the fatalities in terms of the percentage numbers have come from a single nursing home type setup in Washington. Most of you are hearing that over the last several days, and we will come back to that. So extremely common, extremely rapid spread, but fatalities and person-to-person spread still, on a relative sense, somewhat on the low side compared to, for example, either SARS or MERS or Ebola. And we'll draw that distinction later on again. This one, again, you're very familiar with. This is straight from the CDC. And the focus of this slide primarily is that the bunch of cases in terms of the density of the cases continues to be in California and Washington states, although rapidly, it's an evolving process. And as most of you know, there are now cases pretty close to us, including New York and Pennsylvania, which I'll get to in the next slide. Here are the cases in Pennsylvania. 4 cases are reported to date, 2 cases reported yesterday and 2 reported earlier in the week. The 2 reported yesterday, important to note, Montgomery County, an adult male and an adult female residing separately in 2 different parts of the county. So there was no relationship there. The key point is both were treated for mild symptoms and they were exposed in a part of the country where disease is known. It seems like it's within the United States. The 2 cases earlier in the week, one from Delaware County, a woman who traveled to a part of the country with known disease, seemingly within the United States, and Wayne County, this is the person who traveled to a country known to have disease. I believe it was Italy. Both have mild symptoms. So all the 4 in Pennsylvania, 3 acquired within the country, 1 acquired outside the country. All of them have mild symptoms and seem like they have cold-like symptoms and are likely to recover. So that's very important. And we'll keep coming back to that. Relatively mild disease, very similar to the common cold and at worst like influenza. But then there is a subset of people that we will focus on where there is a phenomenally high incidence of issues and problems, including mortality and death. And we'll get back to that. And what we as a community need to think about doing, particularly in those populations. So how is it spread? Early on, many of the patients we've already talked about, it probably came from an animal source. The best guess right now is from bats, but it could be from other animal sources. And later, as we said, person-to-person transmission. And this is pretty well established now. So how does that happen? We'll get into that in just a moment. This slide is a critical slide. If you don't pay attention to any other slide, this is the slide I want you to pay attention to, because this is where all of the preventive things are grounded on. And this is also where a lot of the preventive techniques are grounded on. So let me make a statement that this slide, this knowledge base has been established for decades. Every time an epidemic comes along where transmission occurs by the respiratory route, okay, the same slide comes out. The same source of information comes out, whether it be influenza, whether it be SARS, whether it be MERS, the principles remain exactly the same. So when the CDC was asked, when this epidemic was beginning to grow, when they asked, what are they doing? What are some of the documents that they're going to be using? Essentially what they said is, we're going to dust off the 2017 guidelines for influenza and essentially use that for purposes of planning preventive interventions as it relates to COVID-19. So I'll spend a minute on this slide. So what happens is that the way things are spread by the respiratory route, as opposed to things like hepatitis or things that we traditionally know as Asian Indians, when we go to India, we are susceptible to, those are spread by what's called fecal-oral methods, meaning it comes from the water, it comes from eating and drinking, right? And that's why we take all the precautions in eating and drinking. As opposed to that, this, as well as influenza and things like that are spread by the respiratory route. And these are the mechanisms. So when you cough or when you discharge respiratory secretions into the air, as you can see here, small droplets kind of come out of the mouth. Most of these droplets fall to the ground within about 3 feet of where you are, right? So you can see most of them falling down here within about, it says 2 meters, essentially about 3 feet, right? Several diseases are transmitted by these droplets, and I'll mention them in a second. The second is, what happens is, in some instances, these droplets evaporate to form what are called droplet nuclei, right here. And these small droplets that are very small in size, they stay in the air, right? So this is where, if you are in a tight space and a large number of people are in a tight space, okay, and it's not well ventilated, this is where these small particles will sort of hang out in the air and potentially cause inhalation and therefore cause disease. So these are the two basic mechanisms of spread. So the first set, where illnesses are spread by the droplet method, meaning if you are more than 3 feet away from a person, you're unlikely to directly contact the disease. Examples of this are listed: influenza, the common cold, meningitis, and whooping cough. These things are typically spread by droplets. As opposed to these ones on the right side are spread by the other method, by the small particles, okay, that's called an airborne transmission. TB is a typical example, which is why TB used to be so easily spread in India, because, and even we as physicians, when we would often walk in, often without protection, we would carry an extremely high chance of contracting TB because it would be hanging out, these organisms would be hanging out in TB wards, and it was not that hard to get. Chickenpox is another example, measles is another example, and SARS-CoV is another example. So where does COVID-19 fit into all of this based on the best available knowledge as we know it today, okay? And the answer is both. It spreads both by droplets. So if you're close to someone, really close to someone, and it is also spread by the airborne route. So if things are hanging out in the environment, so which is why when a suspected patient of COVID-19, and we've had about 4 of them in our hospital that we've taken care of very recently, when they come in, what we do is we place them in a room where there are special ventilation techniques right here, right? So it's called a negative pressure room. And there are special ventilation techniques that are helpful in clearing the air, if you will, right? So that's important. And secondly, that regular masks are not good enough to be able to prevent disease. And there are specific types of masks, which we'll get into in a little bit, where that might be helpful, particularly in healthcare settings. Not so much in the community setting. We'll get back to that in a few minutes. But this slide is critical to spend this kind of time on, as to what the 2 types of transmission are. And I'm happy to send a PDF version of this out later on, so you have this in your mind, and keep this in your mind as you think about, because the better you're educated, the more likely it is that you're going to be preventing helping prevent this in yourself and in your friends and loved ones. So how do patients typically present themselves? And we'll come back to prevention later on. First is, so what are the symptoms and signs? What tests are done? What are some X-ray findings? And so on. So this again is a summary, and you'll be fascinated by this. This was published in the Journal of the American Medical Association, again, very recently, February 24th. I was just fascinated by the fact that 72,000 cases, okay, from the Chinese CDC had been put together rapidly within the course of a few weeks. And much of the data that we currently know from the initial patients who were in Wuhan, China, this is it. This is where it comes from. This is rapidly changing, but importantly, this is a massive body of patients who this is drawing from. So here it is. As of February 11th, and don't go by the specific numbers, I'm interested much more in the percentages, right? The important thing is about 3% of patients were above the age of 80. 90% of patients were between 30 and 80. Most important, if you look at the bottom in the red font, about 81% of these cases were mild, okay? And 14% were severe and 5% were critical, meaning they went into the intensive care unit, had to be ventilated, and so on and so forth. So the important take-home message is about 80%. This is where that number comes from, the 80%. And when someone tells you, well, and there's a lot of this floating around, well, in the US, we are not testing enough, so how do we really know? Well, go back to this slide. If you look at the top part of the slide, many of the patients were not actually tested. After initial testing, if people were known to have consistent signs and symptoms, and by the way, this is fairly common in infectious disease epidemics, if people have consistent findings during the course of an epidemic, then that's how it goes. You assume that's what they have. So these numbers, I think, are fairly representative of what we are dealing with right now. 72,000 is a large number. Okay, so here's the mortality rate. This again has been debated back and forth, but the important pieces are the following. About 2.3% died in this cohort of 72,000 people. As opposed to this 2.3%, influenza mortality is about 0.1%. Okay, so this is about 20 times more fatal than garden variety influenza. Importantly, however, this number of 2.3% jumps up to 14.8% in patients who are above the age of 80. A very important take-home point. Several of our community are those who are above the age of 80, and several of them are otherwise well, okay? You see the other details up there. The next important thing is, among healthcare personnel, doctors, nurses, and so on, you see about 14.8% of cases were classified as severe or critical, probably because of the load of virus that these people received. And there were about 5 deaths in that group. What is the incubation period? Why is this important? Because you've often heard that people are being quarantined. So let's say I get exposed to you who has coronavirus, right? I'm within 3 feet, within 6 feet or whatever, there's a cough, I'm exposed. The odds of me getting infected almost all the time, the odds of me getting infected are going to be within 14 days. Okay, so the incubation period is 2 to 14 days. What that means is, video freeze. Okay. Just want to see how it slides. Slide is okay? No? Okay. No, it's not moving yet. We can listen you or not. Okay, let's see. Okay, apologize for that. The internet connection is back on up again. Can everyone hear me okay? All right, good. Sorry about that. Bear with me a second. Okay, Good. All right. Apologize for the inconvenience. We're back on live. So we were talking about the incubation period being 2 to 14 days. What that means is, let's say I'm in front of you, I get exposed, and I began to get the sniffles 2 hours later. That's unlikely to be coronavirus. Less than 2 days, highly unlikely. More than 14 days seems highly unlikely today. So that's how you figure out, and that's how people get quarantined. If I get exposed and I have to be quarantined to see whether I get the disease or not, it's approximately 14 days that quarantine period sort of lasts. Now, what are the common symptoms? Fever, cough, shortness of breath. Those are the three big ones. And there is a certain unique profile in people who are admitted to the hospital. They can get really sick really quickly, and they can go into the intensive care unit and be intubated and mechanically ventilated. So those are the three main symptoms. Very variable clinical picture. Majority are mild. We've already said that. And if you did an X-ray on these people, many of them, particularly those who are sicker and who get admitted to the hospital, they have pneumonia. And there is a very characteristic type of pneumonia. And I got a call from our radiology colleagues day before yesterday when we were trying to work up a case. And he called me because he was so struck by the fact that the type of pneumonia is very, very typical. It's on both sides, and it has a very specific appearance called a ground glass appearance. And when you get that in the right clinical circumstance, we begin to suspect that there might be something going on that might be looking like coronavirus. So this gives you a very quick idea. If you took all patients, majority are home-based, they're mild, they get better. Some get hospitalized on the right side of this algorithm. Some of them go to the ICU. And if you go to the ICU, particularly if you get intubated and mechanically ventilated, your odds of death or mortality substantially rises, and it can get up to about 40, 45, 50% even in really sick individuals who go to the intensive care unit. So how do we test for the coronavirus? People who are suspected of coronavirus based on signs and symptoms are called PUIs, or a person under investigation, okay? And typically that's a combination of fever, cough, shortness of breath, with an appropriate travel history. So up until now, what we were doing is we were saying, if you've been to one of the 5 countries, right, and you have one or more of these symptoms, by definition, you became a person under investigation, unless you had an easy alternative explanation. You can also get an influenza, a flu, right, in the middle of all of this. If not, you were considered a person under investigation. As many of you may have heard from the media, over the course of the last 5 days, I think, or 4 days ago, I believe it was Monday, that CDC widened that definition essentially to say, if a physician suspects it, he or she can go ahead and get the test, right? So we'll come back to that in just a minute. So how do you do the test? So I'm being suspected of having a coronavirus. How do we figure out that I have the coronavirus or I don't? Okay. So typically samples are taken that are called nasopharyngeal or oropharyngeal swabs. And you see in the picture right here how that's done. Basically, a thin swab is stuck into the nose to be able to get what's called a nasopharyngeal swab. And whenever possible, if someone is intubated and they are being mechanically ventilated, then you can get, by a bronchoscopy, you can get samples from down in the lung. But if not, that's okay. The oropharyngeal and the nasopharyngeal samples are easily obtained within a couple of minutes and sent off for testing. The test is called the PCR test, where essentially you're looking for DNA elements of that particular virus in a special technique called the PCR, where it's probed for that virus, okay? Now, all the way up until now, it was only being done at the CDC, because when they first put it out to state health department labs, some of them were not very reproducible, shall we say. So the CDC took control back. And then as of last Monday, they put them out back again to the Department of Health. And the test, the one case that we were helping work up in our institution, the first test that was sent out, we sent out to the Department of Health lab outside of Philadelphia. And that test obviously came back negative. So It's being done currently in state Department of Health labs. And as of tomorrow, as of Monday, Quest has announced that they will be able to commercially do the test. The details are still unavailable. I'm told they may start from the West Coast, but supposedly Quest is able to do the tests and have announced in a formal announcement nationally that they will be available to do the tests as of tomorrow. Test results typically come back fairly quickly. Let's say if I had it available in my institution, currently it's not. If I had it available when we sent out to the Department of Health lab, the test typically comes back in a couple hours. So you have a quick answer, okay? And just as I said, Quest is to start this on Monday. This is an important slide. When you go through this, the seasonal distribution, this is where a lot of the conjecture comes from as to some people predicting, oh, as soon as it kind of warms up, it'll go away or whatever. This is where that speculation is coming from. No one knows because it's an ongoing epidemic. No one knows. What this shows is the seasonal distribution of MERS, HCoV, and influenza. The gray, as most of you know, is influenza, which typically peaks in the winter months and begins to go away about April-ish, mid-April-ish, it's pretty much gone. End of March, mid-April-ish, it's pretty much gone. Then when you see the one in red, which was MERS, which actually went all the way. So heat or whatever did nothing to it. It went all the way. June, July seemed to go down a little bit, August maybe further down, but in June it was actually peaking. And then finally, the HCoV did begin to go down in April, which is the speculation that perhaps if influenza and SARS were able to go down, perhaps with the summer months, something will happen. And certainly let's pray to God that that's what happens, but there is no scientific evidence that one or the other might happen, or that it might go down only to come back again, just like influenza does every year. So we don't know that for a fact, but that data out in the media comes from this source. Okay, on to, some of you had asked about treatment. What treatment is available? Currently, no treatment is available. There is an antiviral by the name of remdesivir, which I've shown here on this slide, that's currently being, the testing on that has started. When I say testing, meaning what's called patient care's phase 3 testing has started on this. This was used to some extent, or at least in lab models, was thought to be helpful in MERS-CoV. So that's where the background knowledge of it comes from. And the trial that is about to start is actually going to occur where the treatment arm will get, as you can see, intravenous medication, and then there will be a placebo arm, and outcomes will be evaluated at about 15 days. The first patient enrolled in this study has already been enrolled in this study and was repatriated from the Diamond Princess cruise ship. So our hope is that fairly rapidly this can then be tested, and you can get results of those depending on how many patients are able to be enrolled. That will determine how quickly we can get results from this trial. This is again the announcement that this company is looking at the same drug, except they are working through this in China, along with the Chinese CDC and so on. This simply demonstrates that this drug was first tested in the virus that was the MERS virus. So there are some similarities. So that's kind of what the thought is. This is the only drug, to my knowledge, that's currently being tested. There is no drug currently in the market that has any influence on it otherwise. So remdesivir is a drug that's being looked at. Some of you asked about vaccines. Here's the answer. Currently, at least 10 different companies are beginning to look at vaccines. Only one company, the very first one on this list, is anywhere near a phase 1 trial. Along with the NIH, basically the concept of a vaccine is you take a small attenuated part of the mRNA or the RNA from this RNA virus, you take a portion of it, okay, and that becomes the candidate to begin to get into humans to be able to test if they mount an antibody response enough to be able to prevent the virus from replicating, right? There is only one company listed on top, Moderna Therapeutics, which is currently doing or starting a phase 1 trial along with the NIH. The candidate vaccine, when I say candidate, meaning the mRNA has been identified, and It was identified pretty quickly, about 42 days after the novel coronavirus was sequenced, and it is now very actively in testing. Now, how long it takes, there's been this big debate. Person A says minimum of year to year and a half. That is typically what has been suggested by most experts who are immunologists. As some of you may or may not know, Tony Fauci, who's been in the president's task force, is one of the most eminent both immunologists and infectious disease physicians in the country. I know of his work since his HIV work back in the early 80s when the HIV epidemic was beginning. He's an extraordinarily talented individual, and clearly strong evidence seems to suggest that to expect anything less than a year would be highly unusual. If there is any possibility of something coming through, it'll be from this first phase 1 trial. The other ones, a whole bunch of them listed in the bottom of the slide, are preclinical, meaning they're still trying to figure out what the specific RNA type might be that they would then begin to sort of test in humans. So the first company is kind of a little ahead in that process. Okay, so back to our preventive 1 or 2 slides. We've already shown this slide. As a reminder, real quick, small droplets, influenza, the smaller airborne technique of spread, TB, chickenpox, measles, and the COVID-19 by both mechanisms. So why is this important to repeat? Because we are about to talk about the preventive techniques. So the 2 types of, once again, at the cost of repeating, airborne transmission, small droplet nuclei, less than 5 microns in diameter. They stay suspended in air, and when inhaled can reach the bottom of your lungs into your alveoli and cause infection. Droplets are bigger. They fall to the ground within 3 feet, do not require any special handling, right? So if you were in a temple environment with 500 people, yes, if you're within 3 feet of someone and someone's coughing at you, you're likely to get influenza, but you're unlikely to get influenza if that person is on one corner of the room and another person is on another corner of the room. On the other hand, these other ones, if they're less than 5 microns in diameter and they're floating with no negative pressure in that room, odds are very high that large numbers of people can get infected, which was the logic when the question was going around of how many people. Unfortunately, there is no scientific evidence to say is 500 people large, is 100 people large. It depends on ventilatory conditions, it depends on the status of the room, and so on. So for good measure of caution, and certainly from some of you at the temple administration, the question was, what should we do? And really the right answer was, because of the rapid increase in spread, particularly cases moving into Pennsylvania and surrounding states, when asked, we thought it was the most appropriate thing to do to have an abundance of caution and not have events that are very large events in relatively small confined spaces. Okay, now on to perhaps the most asked question about masks. We'll spend a couple minutes because a lot of the questions will revolve around this. So when you think of masks, broadly think of not just masks, but think of what's called respiratory protection, right? It's called personal protective equipment, or PPE, right? And there are 2 types of those. There are masks, which you see on the left side, and then you see what are called particulate respirators, right? So what happens is masks are often used for the protection of healthcare workers when they come into contact with someone infectious. And also, they're placed on healthcare workers to protect patients from infection. So for example, let's say I'm a surgeon and I'm operating on a patient in a sterile field, everything is completely sterile, then I wear a mask primarily to prevent anything infectious from going from my face into the patient. And then vice versa, when the patient has something infectious, I wear it going into the room of a patient. And typically that's what we wear when we go into the room of a patient who might have influenza, right? We don't wear these big N95 masks or anything. We just wear a regular mask when we go in there. Because unless we come within 3 feet and someone coughs on us, odds of infection are low. And if it's a droplet, it gets prevented from coming into the nose and into the contact with the respiratory or nasal mucous membrane if you have a mask, a regular mask. Now, contrary to the regular masks, if you are to protect particularly healthcare workers, right, from something like COVID-19, particulate respirators are the ones that are used. These are the ones that prevent inhalation of small particles that contain infectious agents transmitted by the airborne route, right? That's the one that COVID-19 falls in. That's the one TB belongs to, and so on. I show you an example of the mask. Most of you are well aware of it. They found themselves out of everywhere, including Amazon, every one of the sites, and so on. The way they are designed, they're called N if they're resistant to oil, R if they're, N if they're not resistant to oil, R if they're resistant to oil, and P if they're strongly resistant. And then they are given a number if they're able to keep 95% of these small particulate matter out by special testing by the FDA, then they're called N95. That's the most common form of particulate respirator that is used in healthcare settings, okay? Now, up until now, they were really not used other than maybe in China and sometimes in India to help with preventing exposure to dust and pollution, right? But suddenly everyone's walking around with these N95 masks everywhere, right? So plain regular garden variety mask. Now, all of the comments that I'm now making have to do with research in healthcare settings. There is no research, with this next slide will show. In healthcare settings, the research is what I just told you. Plain masks for surgical purposes when you walk into an operating room, or to prevent spread to physicians and nurses when you walk into a room in someone who has the influenza or and so on. And we in healthcare use N95 respirators when we walk into a room where someone is suspected of having one of the other conditions that I talked about, including TB. But the critical piece is we get fit tested for it very specifically to form a nice seal around our nose and mouth and the face right here. And it takes a certain amount of time. They do special tests. They make sure that there is full protection, if you will, and they fit nice and snug on the face, right? If you don't do that, and I tried this, by the way, when we went to India about 6-8 months ago, if you try to wear these, okay, you can't keep them on your face for longer than a couple minutes. You end up doing this, keeping them away. There's no way to keep them in place. And then secondly, you can never form a seal because they are not meant for your own face. So the level of protection is highly, highly questionable in community settings. And there are no research studies whatsoever to be able to use them out there in the community. Okay, so that's important, and we can come back to that in a few minutes. So what do you do? The single best way to avoid is not to be exposed at all. So avoid close contact in people who are sick. Avoid touching, because what happens is, remember that same big chart again, someone coughed, right? Those droplets can fall to the ground and be on surfaces and last for a short time, not too long. But let's say you are touching a railing. You went to the Hari temple, there were 50 people. One of them had a communicable disease spread by droplets. You touched the railing, the person walked up. You didn't know they're in there. You walked up now, up the temple steps. You touch the railing, and then you go like this, and you now touch your nose. There is a direct contact with the droplets that go straight into your nose and cause the infection, right? So the answer, which is the single most important way to prevent spread, whenever possible, okay, stay at home when you're sick, cover your cough or sneeze either with a tissue or sneeze into your elbow or cough into your elbow, okay? That way it's not in your hands and you're not transmitting it into what are called inanimate objects or fomites, and then somebody else doesn't come along and touches that and then gets hurt by that process, right? The next best thing is that you can wash your hands, either wash your hands in between such encounters, or if you have a hand sanitizer, the key is to carry this along with you, a hand sanitizer, a good old Purell, okay? But there is nothing magical about Purell. If you don't have it, good old soap and water does the best hand washing known to man, okay? So you can certainly do that. Disinfect frequently touched objects and surfaces, which is why you see frequently, in fact, even in yesterday, they were showing in the media, Costco workers trying to disinfect carts and so on and so forth. Always a good idea. But the most important thing that you have full control on is hand hygiene, repetitively washing your hands. Okay, on the last slide, and then we'll open it up to questions. This slide comes from Dipankar, which is on COVID-19 in animals. This question comes in the context of pets, I guess, right? Most often, yes. So no conclusive evidence of infections with COVID-19 in animals. Infected persons should, however, maintain some distance from animals, but importantly, there is no conclusive evidence that COVID-19 is existing in animals as we speak. Okay, on to questions, some that have already been sent to us. So I'll walk through them, and then we'll open up the lines or open up the chat function. I don't know if you can still type it. And you can, by the way, still type in your questions as we speak. I have someone who's monitoring the chat lines, and we will answer your questions. The first question: should I mask when I'm outside? The answer is there is no evidence that masking in a regular community environment does any good, okay? Now, if you are sick with the cold or what looks like the cold, the ideal situation is don't go out, stay home. The next best situation is if you have to be somewhere and you want to wear a mask to protect others, that's a good idea. But a mask to protect yourself routinely, how long will you wear the mask? Where will you wear it? Okay. And if you keep removing it, taking it off and on, it's not going to help if it's an N95. And if it's not an N95, it's not going to help you anyway. So that's the logic of don't go crazy over masks. Okay. When the mask shortage came about, one thing I was really worried about, if there is an older parent at home, okay, that's a situation where particularly even if it's a plain mask, at least preventing droplet stuff going in may not be a bad idea to protect themselves, okay? And if there is any situation where there is the possibility of that exposure, maybe there is an opportunity to be wearing an N95, but not tested at all in the community environment. So you're kind of on your own. There is no evidence out there, okay? Gatherings, congregations. Some of the largest questions I'm getting has been around gatherings and congregations. What is large? What is small? Unfortunately, no data out there, only because it's determined on so many things that are beyond our control. So for example, a room that has excellent ventilation with open windows, right? There are 6 windows, all of them are open. There are multiple air exchanges naturally happening, is very different than the same room when the windows are closed and the doors are shut. Right? So there's no way to control that. So what I've been telling people is when an active epidemic is unfolding, right? In public health, the basic rule of thumb, okay, is prevention, particularly involving people who are vulnerable, right? Are older, are elder members of our community, for example, those with lung diseases and so on. In order to protect them and to protect our community, it is prudent, that's not panic, it's prudent to avoid gatherings that have large numbers of people. I don't have a number for you. As many of you know, large gatherings in our temple that had upwards of 500 or 600 people together, very wisely, the team made a determination to suspend those activities, right? Smaller ones where there are 100 people or less, you could debate one way or another. That kind of falls in the middle. You could debate that. And again, between 100 to 400, a lot depends. Is it outdoors? Outdoors is much less likely because the air is out there. There is an opportunity for these particles to be disseminated as opposed to in a closed space with poor ventilatory mechanisms and so on. So that's the best guidance that we can give you in that regard. And then happy to explain more specific functions, if you will, right? Can I travel? Questions to me have come all the way from, can I go to Disney? Yesterday, 2 of our unit clerks at the hospital asked a question, can we go to Disney, right? And I did my usual triage. I said, how old are you? Do you have lung diseases? Have you, are you around people who have any one of these high risk things? And if you don't, I suggested to them at the time, okay, this was actually not 2 days ago. This was about 5 days ago or 6 days ago at the time. Maybe I would have said something differently now, but I said, you've got tickets that's reasonable to go ahead, right? On the other hand, when the same question was asked in the setting here, knowing that there are large numbers of people with potentially who are potentially vulnerable, we thought it was prudent to cancel events. So it's relative, it's not absolute, but I hope you will consider thinking about the foundational elements of what I talked about when you make such choices. So we've talked about, can I travel? Clearly travel to the 4 or 5 countries that we talked about. I don't think anyone's asking that question of me. Most people are not heading that direction. But many, many people I know for a fact have clearly canceled cruises. Needless to say, a great idea. Can you travel within the continental United States? I think the answer is yes, as long as you're not going to be part of large congregations or very large scientific meetings or other meetings. I think you're okay. Hand sanitizers, we've talked about. This is your best friend. If you don't find this, soap and water will always be the perfect hand wash. If you do soap and water, nicely scrub and for at least a couple minutes. While this, you can get away with 30 seconds. Self-quarantine. The question comes up, if I'm exposed to someone, how long should I self-quarantine? If you're exposed to someone suspicious, the amount of time you need to self-quarantine is 14 days, based on the 2 to 14-day incubation period. What I don't know the answer to, and this question was asked earlier today by someone, one of my colleagues, is do we know, let's say I have coronavirus, do we know how long I remain infectious if I get it, right? How long can I transmit that if I get it? And unfortunately, the answer is not very clear yet. The cases in China where testing has been done right, left, and center, they've been actually doing a lot of tests. What they've done is they would remove people from quarantine only when the symptoms were gone and 2 tests were negative, right? It's hard enough here in this country right now to get 1 test on suspicious people. I mean, I had to literally make a case to the Department of Health to be able to get a test done. Now that, I'm told, has changed, and I don't blame anyone because there was a shortage of tests at the time. So that was only appropriate to do. But now more testing is going to become available, and therefore potentially you can test people, and if they're negative, they can be removed from quarantine. Is not quite the right word, but can be removed from isolation, I should say, right? Unfortunately, there is no magic day though, that after 10 days of symptoms or something that you can go off quarantine. And finally, I'd re-emphasize before I close and then open it up for more questions, your biggest risk group, okay? So when there was this mass shortage and all of that, the only people who were coming to mind was not people like us who are otherwise relatively healthy, but people who are older, people who are above 75, 80, or people who have underlying lung disease particularly. They're the highest risk group, and do whatever you can to kind of have a protective process built around them, whether all of the things that we talked about. That's your focus group. The other folks, God forbid, even if they got COVID-19, odds are 8 to 9 out of 10, they're going to be just fine. They're going to get better. It's just going to be like a bad cold and they're going to get better, right? But it's that vulnerable population that we've got to focus on. Okay, so with that, let's see if I have. Okay, so do we...
Are women or are men or women more susceptible?
Susceptible. Okay, so are men or women, okay, there you go, more susceptible? No, not really. And even if there was a little predilection, you wouldn't know what to make of it. The ones in China, the 72,000 number, those ones were 49, 51. It was highly variable. So in terms of outcomes, whether women suffer bad outcomes or men suffer bad outcomes is unknown. I have a cough and cold. Do I rush to the hospital or watch for something else? So if you have a cough and a cold, a couple of things. If you just have the sniffles, nothing. You're treated just like anything else, right? When COVID-19 was not around. The key is 2 things. One is if along with that, you have a fever above 101, or you have shortness of breath, one or both of those, along with the sniffles, along with a runny nose, if you have that, even then, don't rush to the hospital. I would strongly suggest, if you are able to reach your physician, call them first. The logic is, if you walk in there, right, without a mask, and God forbid if you had COVID-19, people who are there would not be able to protect themselves. So what we've been telling people in our hospital is, before you run to the emergency department, unless you're really sick, of course you have to do what you've got to do. But if you're more electively sort of look like you're getting sicker, try to call your doc first. What they can do is they can either get you to the office and get you tested, or they can tell you go to the emergency department and they can alert the emergency department that you're coming and appropriately take infection control precautions. How long does the virus live once out in the open? Great question. So how long does it stay on inanimate objects? We don't know for sure yet. What we do know is that it probably doesn't last a very long time on inanimate objects. And by that I mean, it would be unusual for the virus to last longer than about 10 minutes on inanimate objects, right? So the example that I gave you earlier, someone walking up the temple steps, touching the railing, okay? Odds are high, if 10 minutes have elapsed, odds are high that the virus is gone. However, there are no guarantees, it's still evolving, but on inanimate objects, it is unusual to have the virus stay long. Should our elder relatives preemptively get something like a pneumonia vaccine to either eliminate symptomatic something or reduce symptom severity in case? So the question was, should our elder relatives get the pneumovax and the flu vaccine? The answer is always yes, right? If you're in the right age group, if you're above the age of 60, you need both of those vaccines. They're both safe vaccines, and you should get them regardless. Because in the middle of all of this one patient we were evaluating yesterday actually went to Italy, went to northern Italy, came back, was seen by us, and found to have influenza. However, that's the one I was talking to you about earlier, where the radiologist called me and said he has this lung findings. So we admitted him to the hospital just to make sure we would test him for COVID. We got the samples, he got better, he got sent home, and tomorrow morning we will be sending the samples over to the Department of Health to get testing done. So the answer is yes, always to those vaccines. There was a time when I did not get the flu shot frequently because I used to get significant side effects. 3 years ago, I began to have it regularly. Even if I needed to live with some of the side effects, I've consistently had the flu shot. And pneumovax, if you're older, absolutely goes without saying you should. Should air travel be avoided to cities that have reported cases of this virus? Unfortunately, that's a judgment call. No good answer to that. Should you stop going to the places, Seattle, California, and so on, or Washington State, California, and so on? I don't think there's any evidence for that at all. There are appropriate ventilatory processes in place in airplanes that potentially, in our model earlier, the model of airborne transmission, that potentially helps, unless someone is sitting right next to you and all the mechanisms we described, touching the side of the railing and so on and so forth. That is one situation, specific situation, that if you were in an airplane, okay, where you don't have control, if you had a mask where the opportunity existed to be able to help yourself, that may be one specific instance where it actually might come in handy. The other thing that might come in handy always. Okay. Do we see a doctor if suspected of having this disease? We went through this earlier on. If the symptoms are mild, it's perfectly okay to stay at home. You're likely to get better one way or another. You don't have to see anyone. Now, if the symptoms, as I said, fever and shortness of breath accompany the other symptoms, it's a good idea to call your physician. And as more tests become available, odds are high that you're likely to be tested, because that will help in preventing transmission. If you are known to have disease and you have an elder member of the family at home, appropriate infection control precautions will need to be taken. And therefore, it will be a good idea to go to the doctor. Right now, there is still a significant testing shortage. People middle-aged with asthma are in the vulnerable group, ? Yes. People with any underlying lung disease that compromises asthma, a lot will depend what type of asthma they have. If they have very episodic asthma that happens once or twice in the year, probably not. On the other hand, there are asthmatics who get frequent episodes and who go on prednisone fairly frequently. They are just as high risk as anyone who's older. So yes, it depends on the person. If very mild, probably not. If anything more than mild, yes. Self-quarantine for older vulnerable in homes as preventive measure, will that help? So I'm assuming the question is, if you have an older member of the family, do you just sort of quarantine them? The answer is not really. But what you do is don't place them in situations that will be at risk. I would not send them to places where there are groups. The threshold is even lower there, which is don't send them to groups where there are 200-300 people together in less ventilated settings, for example, and so on. And don't send them to places where you don't have control that someone may cough on them, right? So use some common sense evaluating the situation, yet you can't just, get the elderly folks only at home and not have them get out, because we don't know how long this process is going to last. Okay, so this is slightly longer, but I'll read it out. There are a lot of remedy videos and information floating on social media, like some plant, boiling it, garlics in 7 cups of water, eating the garlic and drinking the water, and also on self-diagnosis, like take a breath in, hold the breath for 10 seconds. So this seems to come from Babaji, right? No, I'm just kidding. So this one, unfortunately, no treatment modalities are currently available. I have always said this in the context of herbs and natural remedies. If any of the natural remedies are natural products which are harmless, if you want to play around with this, be my guest. I've generally said to people, there are many practices, there are many things. It would be arrogant to say we know everything. We don't know what we don't know. And therefore, anytime when there is something reasonable, okay, reasonable as in, always talk to your doctor that it doesn't hurt you. If it doesn't hurt you and we don't know what helps you and you want to take something, I've always believed that's okay within reason. Follow up the asthma question. Why are we not shown the number of people recovering from the virus and we only see the increasing number of cases and deaths worldwide? Why is there no positive news? That's more of a political question. I don't know the answer to that. I agree with you. I think part of our job as medical professionals is to bring the facts to you, which is what we have attempted to do, which is why I err on the side of being more scientific than less scientific, because I believe that science dispels myths and dispels rumors. And if you are equipped with the right knowledge, you will be able to make decisions on your own. Follow up on the asthma question. Do folks with seasonal allergy become more susceptible in the next month or two? And then the next one is, does Lysol disinfection spray kill the virus? It certainly, Lysol will clearly cause the virus to be either killed or the viral load will go down significantly. So yes, it's an appropriate disinfectant for the virus. But back to the asthma question, I think the seasonal allergy question real quick is, the seasonal allergy question is, seasonal allergy in and of its own does not cause reversible or other lung issues. Sometimes seasonal allergy can cause what's called bronchospasm like asthma. Some of those people go on steroids. That makes them high risk. If they're not on steroids, they're just on regular remedies or Claritin or something like that, the odds of them running into more problems are unlikely. Not impossible, but unlikely. There are a lot of messages saying that the virus lives for 10 to 12 hours on surfaces. That's not true based on what we currently know. If we are older and live independently, can we go to grocery stores and pharmacies without worrying? Yes, absolutely. If you're old and you're independent and you need to go to grocery stores and pharmacies and all of that, absolutely you can. I would just suggest that keep your best friend with you, and whenever you get the opportunity, keep sanitizing yourself, because what you touch, you sometimes don't think. It's quite amazing how many times I have to remind myself, even during the presentation. I've taught this a zillion times, and yet my hand goes here, right? That's natural. It's human. We are all like that. So, but you can't stop living. You've got to go to the grocery store. You've got to go out. That's absolutely fine. But make this your best friend. So those are, though I think we've gone through pretty much most of the questions. Most of the questions that are on the chat line.